Hypersensitivity is a global oral health issue and a significant challenge for most dental professionals. Dentin hypersensitivity is one of the most common complaints from patients in dental clinics. In fact, hypersensitive tooth is an age-old complaint. According to the Canadian Consensus Document 2003, dentin hypersensitivity has been defined as pain derived from exposed dentin in response to chemical, thermal, tactile, or osmotic stimuli, which cannot be explained as arising from any other dental defect or disease. Different terms have been used to describe dentin hypersensitivity. Common terms which are used refer to dentin hypersensitivity as dentin hypersensitivity or dentin sensitivity, dentinal hypersensitivity or dentinal sensitivity, cervical hypersensitivity or sensitivity, root hypersensitivity or sensitivity, or segmental hypersensitivity or segmental sensitivity. The prevalence, distribution, and appearance of the disease have been reported differently in different studies. These differences are due to the differences in populations, habits, dietaries, and methods of investigation. 14.3% of all dental patients between 8% and 57% of adult dentin patients and up to 30% of adults at some time during their lifetime experience dentin hypersensitivity. Among periodontal patients, the frequency is much higher, about 60 to 98%. Dentin hypersensitivity has been shown to peak in 30 to 40 years olds and then rise again when they are in their 50s. It is more prevalent in female individuals. That would probably be related to their dental hygiene and dietary habits. A more current study conducted in India by Sood et al. With 2051 subjects stated that the age group of 60 to 69 years showed minimum hypersensitivity. The condition generally involves the facial surfaces near the cervical aspect of teeth and is very common in premolars and canines. Talking about the etiology, dentin exposure can be caused by physical, chemical, pathological, biological challenges. Various clinical conditions thought to play a role in the development of dentin hypersensitivity include enamel attrition and erosion, corrosion, abrasion, and abfraction. Periodontal tissue loss or gingival recession is another major predisposing factor since this leads to exposure of cervical and root dentin. Other factors such as aging, soft tissue dehiscence, including aggressive brushing, can also cause apical displacement of the gingival margins, thereby leading to exposure of dentin that can ultimately lead to the development of dentin hypersensitivity. Taking a look at the pathogenesis of dentin hypersensitivity, so we know that there are differences in the dentin of crown and root and throughout its structure basically. In the crown, the tubules follow a double curved course, but in the root and beneath the incisal tips, the tubules take a straighter course. The circumference of the dentin at the peripheral part of the root or crown is much greater than near the pulp, leading to the columnar appearance of the odontoblast as they are squashed together, especially over the pulp horns. Now, let's take a closer look at the dentinal tubules. So this is a magnified view of the dentinal tubules. The number of tubules per unit area and radius of the tubules increases from enamel cemental junction, where it is approximately 20,000 per square millimeters, to the pulp, where it increases to about 45,000 per square millimeter, as does the tubule lumina, resulting in the water content or wetness of the dentin increasing to about 20-fold from superficial to deep dentin in patent tubules. So this may have clinical implications. If the deeper dentin is exposed to the oral environment, it has relatively larger dentinal tubules in close proximity to each other compared to the original surface dentin structure of the tooth. So if there is a large tooth defect, there will be exposure of larger dentinal tubules. This has the potential for more rapid tubular flow. Thus, larger cervical wear is more sensitive as it exposes the wider portion of the dentinal tubules, leading to more hydrodynamic turbulence. Thus, greater tubular occlusion is necessary to alleviate symptoms. On the other hand, the tooth has excellent reparative capability with reactionary and reparative dentin deposition, giving rise to considerable heterogeneity in tissue structure, from regular to dysplastic atubular structure. This grossly worn dentin is rarely sensitive, hence decreased prevalence of dentin hypersensitivity beyond 50 to 60 years of age, as we just saw. Whereas rapid wear in a young adult is often sensitive, resulting in pain symptoms. The pathological process of dentin hypersensitivity can be broadly divided into two main steps. The first being lesion localization, wherein the dentin surface of a tooth must be exposed, and then lesion initiation is the second step, where a number of dentin tubules in close proximity to each other become patent from the pulp to the oral environment. The most common etiology of exposing radicular dentin is recession of the gingival margin nerve tissues. This process is characterized by the displacement of the gingival margin apical to the cementum enamel junction, thereby exposing visible cementum of the root surface, which is then rapidly lost, as we know that the rate of wear of cementum is much higher than dentin. For the exposed dentin to be sensitized, the tubular plugs and the smear layer are removed, and consequently dentinal tubules and pulp are exposed to the external environment. So there is a continuous outflow of fluid from the open tubules. If stimuli are then applied to the dentin, the rate of flow is increased, in turn exciting the nervous system and resulting in a pain sensation. So let's look at the mechanism behind dentin hypersensitivity. A variety of theories have been suggested to explain the mechanism involved in the etiology of dentin hypersensitivity. The transducer theory, the modulation theory, the gate control and vibration theory, and the hydrodynamic theory have all been presented and discussed throughout the years. None of these mechanisms fully explain dentin hypersensitivity, indicating unexplained mechanisms are possibly responsible. So let's discuss a few noteworthy ones. So regarding the first theory, direct innervation theory, it has been reported that the nerve endings enter dentin through pulp and extends to the DEJ, and the mechanical stimuli directly transmit the pain. However, there is little evidence to prove this theory, firstly because there is little evidence that can support the existence of nerve in the superficial dentin, where dentin has the most sensitivity, and secondly because the plexus of rash curve do not become mature until complete tooth eruption. However, the newly developed teeth can be sensitive too. Moving on to the second one, the second theory is odontoblast receptor theory. In this theory, odontoblasts act as receptors of pain and transmit signals to the pulpal nerves. But this theory has also been rejected since the cellular matrix of odontoblast is not capable of exciting and producing neural impulses. Furthermore, no synapse has been found between odontoblast and pulpal nerves. And hydrodynamic theory, which is currently a widely accepted theory. Hydrodynamic theory for sensitive dentin was first proposed by Brainstorm. This theory is the most widely accepted theory for dentin hypersensitivity. The theory has been proposed based on the movement of the fluid inside the dentinal tubules. So the theory claims that tubules are open between dentin surface, which is exposed to the environment, and pulp. It is believed that dentin hypersensitivity is made as the result of movement of the fluid inside the dentinal tubules, which is further due to the thermal and physical changes, or as a result of formation of osmotic stimuli near the exposed dentin. The movement of fluid stimulates a baroreceptor and leads to neural discharge. The process is called the hydrodynamic theory of pain. This process is similar to activating the neural fibers around the hair by touching or pressing the hair. The movement of fluid can be toward the inside of the pulp or the outside of dentin. So in this image, the shaded region corresponds to the fluid movement. Increased rate of dentinal fluid flow generates an action potential in the intradentinal nerve endings. Cooling, drying, evaporation, and hypertonic chemical stimuli cause the dentinal fluid to flow away from the dentin pulp complex and lead to an increase in pain. Heating causes the fluid to flow toward the pulp. Now, there may also be passage of fluids through the enamel, because the enamel may be thought of as a semi-permeable membrane that allows passage of fluids and small molecules through the organic defects between the enamel crystals. According to Berman, the coefficient of thermal expansion of the tubule fluid is about 10 times that of the tubular wall. Therefore, heat applied to dentin will result in expansion of the dentinal fluid, and a cold stimulus will result in contraction of the fluid, both creating an excitation of the mechanoreceptor. We saw previously that the number of tubules in sensitive dentin is 8 times more than the number of tubules in non-sensitive dentin. Furthermore, tubules of sensitive dentin are wider than those in non-sensitive dentin. The most important variable affecting the fluid flow in dentin is the radius of the dentinal tubule. So if the radius is reduced by 1/2, the fluid flow within the tubules falls to 1/16 of its original rate. So basically, the rate of dentinal fluid flow is directly proportional to 4 times the radius. With time, the organic channels become plugged due to the formation of organic biofilm consisting of calcium phosphate in the saliva and calcium and collagen from the odontoblasts. In healthy patients, saliva is normally very effective in reducing dentin hypersensitivity. Saliva provides calcium and phosphate, which over time occlude open dentin tubules. Pro-argent technology was developed based on this role that saliva plays in naturally reducing hypersensitivity, which we'll see in the treatments section of the presentation. When this plugging in or occlusion occurs, the bidirectional flow of fluid stops, and so does the pain. Thus, the creation of a smear layer or the occlusion of tubules will significantly reduce sensitivity, and this occluding mechanism is employed by many anti-hypersensitive agents to reduce dentin hypersensitivity. Talking about the treatment of dentin hypersensitivity, so the first line of treatment for dentin hypersensitivity is, of course, prevention. So if the diagnosis confirms dentin hypersensitivity in the absence of underlying diseases or structural problems of the tooth, then the following steps can be initiated. The first one being remove the risk factors by educating the patient about dietary acids and other oral care habits. Second, recommend different toothbrushing methods if appropriate. So if the patient has a deleterious toothbrushing habit, so we can recommend the most commonly accepted toothbrushing method, that is the modified BAST method. Third, initiate treatment by recommending a desensitizing agent for home use. So there are different types of desensitizing agents which work on different mechanisms by occluding the dentinal tubule, which we'll see in another presentation when discussing the treatment methods. And finally, applying topical sensitizing agents in office can also be done. So this was about dentin hypersensitivity, its clinical features, pathogenesis, and the treatment steps. In a separate presentation, we'll look at different agents available for treating dentin hypersensitivity and the various methods to treat dentin hypersensitivity.